I'm really excited today to have an opportunity to interview Donna Hurlock about her new book, Patient-Focused Hypothyroidism Treatment. And Dr. Hurlock, or as we call her, Donna, is going to be sharing some really incredible information about what motivated her to write the book, what the book is about, and why patients and practitioners really could benefit from this groundbreaking, and in many ways life-changing information about hypothyroidism diagnosis, treatment, and management. So first off, I'd like to welcome you, Dr. Hurlock, and I'm excited to have an opportunity to interview you and to get the word out to patients and practitioners about your new book. So welcome.
Thank you very much, and thanks for this opportunity as well.
You're very welcome. All right, so let's get started talking about the information in the book. But before we do that, I really want to get a little bit of background so people who may not be familiar with you have a little more information about where you're coming from in writing this book. So tell us a little bit about your background. You went from being a newly minted OBGYN out of med school residency, internship, into starting your own practice and ending up being really a nationally known women's health clinic for hormonal health. So how did that happen?
Well, I started out as an OBGYN because I like taking care of women, and I liked the ability to do surgery sometimes, and of course delivering babies is fun. But that's also a very risky occupation, and it got to be a little exhausting with worrying about obstetrics. So I retired from obstetrics after 5 years of that and just started doing gynecology. And that was way back in the 80s when there weren't many female gynecologists. So I started attracting more and more menopausal age women because they wanted to seek out a doctor who wasn't going to be running off delivering babies. And, you know, they had businesses to run and jobs to go to, and they didn't want their appointments canceled by somebody who's going off to deliver a baby. So I started being somewhat of a menopause expert and was one of the first certified menopause clinicians in the country because I simply had attracted those kind of patients. And of course, back in the 80s and 90s, hormone replacement therapy was the thing to do, and as far as I'm concerned, still is. So I achieved quite an expertise in menopausal management. And then at the end of the 90s, I learned from a friend of mine that I was hypothyroid when I discussed my symptoms with him. And that was Alan Gaby, and I talk about him in the book a little bit. So I started managing myself for my thyroid disease and got dramatically better. My symptoms resolved. And then I started seeing similar symptoms as my patients. So I discussed with them, hey, would you like me to treat what I believe is hypothyroidism? And they, of course, let me do it. And they started getting dramatically better too, even though their blood tests didn't show that they needed thyroid. So I started doing that more and more. They started sending their friends and their daughters and their mothers and their sisters to me. And through word of mouth, I had quite a following of patients from all around the country, even some people outside of the country who came to me specifically for women's hormonal issues. Most of them also were menopausal, but not all of them. Some of them were young, but they came to me because I had done a good job managing their thyroid condition. So that's how I got to where I am now.
Okay. Well, you recently retired from active practice, and you are living the good life down there in Florida. I know that you love to boat, and you have a beautiful home and sunshine and palm trees and the whole bit. So why not just enjoy some fun in the sun? What motivated you to take on a monumental task of writing a book? It's a huge project. When you could be out running around having just fun all the time, you decided to say, I have to put my approach to hypothyroidism diagnosis and treatment in a book. What was the motivation for that?
Well, I've been working on it actually for a number of years. I started working on it before I retired, because I knew it someday I was going to stop. I was going to stop taking care of patients. I didn't know when that was, but I knew I was going to stop. And I knew that there really weren't a lot of other doctors out there who were interested in doing thyroid replacement the way I have been doing it. So I wanted to collect the information and write it down so that not only could my patients and maybe other patients who never saw me would be able to understand their condition, and better yet, perhaps clinicians could take what I've learned and use that information to help them better manage their hypothyroid patients. So it's like you want to give your legacy, you want to hang down the information, so that others can take care of patients, because my biggest guilt is that I've stopped seeing my patients who were really dependent on me for many years, but they of course understood that I just couldn't do it forever. But the process of them finding a new doctor to continue their management has been tough for them. And I thought that perhaps writing down all of the things I've learned could help other doctors who were open-minded and interested to kind of take a fast track to learn what I've learned, so that they could manage the patients in the same way that they've been managed.
Okay. I think one of the themes, because I read the book, I'm familiar with it, and I love the overriding theme, which is there is a lot of time that you're spending in the book comparing the old way of diagnosing and treating hypothyroidism with what is considered the new way, or the conventional way, or the standard of care that has come to be the accepted approach that a lot of doctors sort of latch onto these days, as far as diagnosing and treating hypothyroidism. You have come down pretty firmly in the book. I mean, I think it's pretty unequivocal about, as on the side of the old way. You've got a lot of criticisms of the way it's being done today. Can you explain a bit about the difference between the old way and the new way, and why you feel patients are better served by the more old-fashioned or older way, as you've outlined it in the book?
Right. Well, I think a lot of old skills are disappearing in many areas. But when hypothyroidism was originally treated 100 years ago, doctors made the diagnosis based on their knowledge of basic physiology and what happens when a mammal's thyroid starts malfunctioning. They learned it from sheep. If you surgically remove the thyroid of a sheep, what happens to that sheep? They start getting sluggish, they lose their hair, they get tired, they have all sorts of problems. And so when doctors back in the old days, when they talked to patients and touched them and did exams, would see a patient with those types of symptoms, they would conclude, gee, maybe it's from low thyroid function. And so they would analyze the cause of the problem rather than just simply labeling it as, say, fatigue syndrome or something like that. They would say, well, why is this patient having these symptoms? They would figure out that it's low thyroid function, and then they would be able to give the patient thyroid hormone. At that time, it was just desiccated pig thyroid hormone. And they would give enough to the patient, gradually increasing the dose until the patient felt better. And then that was it. That was the end of the process. And they stayed on the dose that made them feel well. And the patients stayed well and healthy and didn't get obese and didn't get depressed, and they were well. But that all changed in the 60s and 70s when the thyroid blood tests were given to doctors. And all of a sudden, the goal was no longer to make the patient well, but the goal was to make the blood test normal. And that's when everything changed. And that's when health of hypothyroid patients dramatically declined. And that's when we started seeing more massive, widespread obesity, depression, ADD, all sorts of health issues, even
Mhm.
diabetes.
Right.
You start gaining weight. So we had a lot more of these chronic health conditions after the diagnosis and treatment of hypothyroidism was changed to be focused on blood tests rather than clinical outcome.
Mhm.
And of course, that makes the drug industry happy because they have more diseases, chronic diseases to treat, which they
Right.
like. But it didn't do such a good thing for patients. And it's just a shame. It's just unfortunate that that's happened to healthcare. So yeah, I'm critical because the change in the way hypothyroidism is managed, standard of care, has done a lot of harm to patients. And
Mhm.
that's why I was so busy. It's not hard to find a lot of ladies who are hypothyroid and undertreated or not treated
Yeah.
because the blood tests don't give the doctor permission, at least that's how they feel
Right.
that they should work. The doctors don't give permission to treat the condition, even though the doctor recognizes that the patient is tired and cold and depressed and has all these symptoms. But my God, if that blood test doesn't say they're hypothyroid, then they're afraid to treat the patient. So it's a tremendous disservice to the patient. And it also puts the doctor in a bad situation because the doctor looks like he's stupid. I mean, because they don't make the patient better. And then
Right.
the patient has to go to another doctor or seek another diagnosis,
Mhm.
end up in a wheelchair with a diagnosis of fibromyalgia and on chronic disability. That's no
Mhm.
way. That's no way to treat patients
Right.
when so many of those patients, if they were just given enough thyroid, they could get out of that wheelchair and start smiling and feeling better and being productive. But no, the standard of care makes you
Yeah.
depend on the blood test and not your eyes and ears.
Well, you raise an interesting issue, though, too, about the profitability for drug companies and such that are, and it's kind of an insidious element to all of this because, you can go to Walgreens or Walmart and get thyroid medication for less than $5 or $6 a month in some
Sure.
cases. It's very inexpensive. But if I have high cholesterol and I've developed type 2 diabetes or insulin resistance, and I've got, blood pressure issues and all sorts of things that can develop because my hypothyroidism is not being treated. And now I'm on a statin drug and I'm on Ozempic and I'm on metformin and I'm on blood thinners and who knows what else. They've got me on, $500 a month of copays for all of these medications versus $4 or $5 a month for thyroid. And it's because, I'm not a conspiracy theorist about this, but it becomes pretty easy to see that there's not a huge incentive for people to diagnose and treat just thyroid when there's a lot more visits to be had and money to be made in people with a handful of chronic illnesses instead of dealing with the thyroid itself. Is that something you agree with?
Sure, I agree with it. I don't really think it's greedy doctors that are responsible for the situation. I do think that the people who run the drug industry and the marketing, I think that that's where the problem is. And certainly when they first started pushing the thyroid blood tests down our throats back in the 70s, and I discussed this literature in the book, as you know.
Yeah.
They maybe stretched the truth a bit, maybe hid some truth, and just really insisted that these blood tests are the way to go. And my God, you sure don't want to just listen to your patient. And further, they of course tried to make the case that only levothyroxine is the only drug you should ever use. You never need T3. You don't need that old-fashioned armor thyroid stuff. And of course, you and I both know that's not true. Many patients do better if they have some T3 in
I'm
there.
one of them.
Exactly.
Yeah.
I'm not currently on T3, as you know, but I had been in the past, and my patients were on all sorts of different products.
Right.
Again, depending on what product made their symptoms go away most efficiently. And of course, always making sure that you do no harm and don't hurt the patient in any way.
Right. I mean, people always ask me, they say, oh, you've been writing about this for 30 years. What's the best thyroid medicine? And I always say the best thyroid hormone replacement medicine for you is the one that safely works best for you, period.
Exactly.
And if that's a generic, if it's a T4, T3 synthetic combo, if it's natural desiccated thyroid, if it's Synthroid brand, Levoxyl, Tiracin, it doesn't matter. As long as it works safely and best for you, that's the best.
Exactly.
So there's no cookie cutter, right?
Right, exactly. Really, the question is, how should you measure outcome? That's the most important question. How do you measure outcome? If you measure the outcome by the blood test or any blood test panel that you want to use, you're not going to get the right result. If you measure outcome by asking the patient, how do you feel? Are your symptoms all better? Are you functioning well? Is your cholesterol good? Are you sleeping at night? Is your hair better? Is your skin better? If you focus on the patient's wellness and use that to determine your dose, you're going to do a good job. But doctors are trained not to do that and afraid to do that.
Well, here's a question. You've run into a little bit of controversy about the book with conventional doctors. And some of them are kind of distancing themselves from some of the approaches that you've outlined in the book because they're very uncomfortable with the idea that the TSH is not the guiding force, the king, the, all end all be all of the decision-making process. And they are extremely uncomfortable with letting patients operate at a TSH level that is considered low or suppressed or potentially in the hyperthyroid range. And that's even when we have thyroid patients who have perfectly wonderful T4, T3 circulating hormone levels. Their thyroid hormones are in a good place. They're not over medicated. They have no hyper symptoms. They're really getting good replacement, but their TSH is showing up at 0.1 or 0.05 or whatever. And so doctors get all nervous and freaked out, and they don't want to be running low TSH levels, suppressed TSH levels. And in fact, I've had patients that I've talked to who got fired by their doctors because of running a low TSH. And we've got doctors that have said, oh, Donna Hurlock's got great ideas, but that TSH stuff, I don't like that. So what is going on? Why are the doctors so squeamish about treating patients that, you even have tests that are backing it up, because I know from your practice, you never let your patients have hyperthyroid T4 levels. If you would manage them so that they weren't running hyperthyroid.
Well, I certainly didn't let them have hyperthyroid symptoms. Again, I was really focused on symptoms. But T4 is their god. TSH is their god. It's a religion. The belief that TSH measures thyroid function and therefore should be worshipped and never suppressed really is a religion. I can't tell you how many endocrinologists I've asked, how do you know the TSH measures thyroid function? And they don't have an answer. They can't give me any data. I have yet to find any data that shows TSH measures thyroid function. It doesn't. But they get very offended, and it's an emotional response. It's a religion. They believe in their hearts.
So it's an item of faith, not necessarily an item of fact.
Because there's no scientific proof that or data that really supports this belief that TSH measures thyroid function. But when you have 99% of endocrinologists, saying with great authority and arrogance that, oh, well, the TSH measures thyroid function because we say so, to stand up and be that one person that says, well, can you please prove that to me? It's hard. It's hard. You have to be brave to stand up against them. And the reason I allowed my patients to have suppressed TSHs is because I first did it in myself. So back in 1998, when I started on thyroid, I found a dose that made my symptoms better, made my hair come back, made me go to the bathroom normally. I wasn't freezing cold anymore. And I did my TSH and it was 0. And I said, gee, I feel perfectly normal. I'm sleeping well. All my stuff is better. My cholesterol has dropped 50 points and now is 165. I seem to be healthier, but yet this TSH says I'm 0. And of course, I was taught in med school, like everybody else, oh, a TSH of 0 means you're going to die and you're going to have a heart attack and you're going to have osteoporosis and all these things. I said, well, if I do that, I'm not going to sue myself. And, if I break my hip and I'm not seeming to have any heart conditions. I take my pulse every day. It feels normal. It functions normal. My blood pressure is perfect. My cholesterol is perfect. So why don't I wait and see what happens to my bone density? Because I don't have any other signs or symptoms of overdose. And of course, you can't feel your bone density. You have to measure it. So I did a baseline bone density and then did another one a year or two later. Lo and behold, no bone loss. And I said, well, how could this be? Perhaps this TSH that I've been taught to worship is a false god. Because if it's a real god, I should have lost significant bone in these last year or two when I've had my TSH down to 0, but I haven't lost any bone at all.
Right.
And of course, that continues. As long as you're clinically well on the outside, you're also clinically well on the inside. So if your pulse is normal, you're sleeping like a baby, you don't have a tremor, you're not jitter, you're not hyper, you're not losing bone either. I've learned that. Nobody ever taught me that, but I had to learn it. And of course, we have the luxury of having bone density tests. They didn't have bone density tests back in 1960. Even.
Right.
We just started using them back in the late 70s, 80s. And so in my thousands of patients, most of whom had TSHs of 0 on doses that made them well, I made them all get bone density tests. I made them all take their pulse every day, or at least I tried to make them all take their pulse every day. I'm always constantly looking for harm. Let's check your bone density. I need to prove that you're not losing bone, because we've all been taught that you should be losing bone if your TSH is 0. And sure enough, their bone density is fine as well. So you get a little, I just didn't care about the TSH anymore at that point, because I knew it didn't tell the truth. It didn't tell me when a patient was sick, underdosed, or overdosed. So I've had patients overdose. Of course, if a patient is overdosed, if they're on too much thyroid, yes, their TSH will be 0, of course. If they're on the right dose of thyroid, they can also have a TSH of 0. And you can even be underdosed with a TSH of 0. So what good is the test? It's worthless. But the thought of suppressing a TSH, it's like the mortal sin. I mean, oh my God, if you dare to tell an endocrinologist you suppressed a TSH, they want to, call the police.
Right. Well, and as you're saying, it makes a lot of sense, because if you have a patient that comes in that's got a suppressed TSH, but they've got diarrhea and 120 beats per minute heart rate, and their blood pressure is high, and they're shaky, and they're having insomnia, and they're nervous and anxious and having anxiety attacks, that is an over-medicated patient, right?
Of course.
It's pretty obvious. I've had one coaching client of mine who was hyperthyroid, and she said her doctor used to test to see whether she was at the right thing by sneaking into the examining room and clapping his hands behind her head, and if she jumped off the table, he would know she was super hyper. I mean, not a particularly good, acceptable way of making a diagnosis, but it was obvious she was, jumpy and jittery and nervous. Reflexes were super, fast, etc. But the fact that we've got this medical world that, to a large part, is looking at patients who have no clinical signs of anything other than they're doing really well, and even in many cases, they're coming in with the T4 and T3 tests to back up the fact that even though their TSH is suppressed, they're in the reference range on these 2 circulating thyroid hormone levels, but yet they're still paying more attention to a pituitary hormone, to the TSH, than they are to the patient's symptoms and the actual blood tests that say, this is what's going on as far as thyroid hormones circulating in the body. I mean, it seems to me to be very illogical. And I mean, how much common sense is involved in saying if the actual hormones are doing fine and the patient is doing fine, we shouldn't change something. But yet this is an argument patients have every day with their doctors. Why do you think that is?
Again, it's just the dogma. We're taught a certain set of quote facts in medical school, and this is what the professors told us, so therefore it must be true. And how dare you question the dogma? You know, that's just not allowed. But really, I kind of enjoyed trying to pin down endocrinologists and say, you know, prove to me that a TSH measures thyroid function.
Right.
And they just want to change the subject. I have a quote in the book from a big shot endocrinologist at Hopkins, you know, essentially, how dare you ask me that? You know that the TSH measures thyroid function.
Yeah.
And, you know, discussion over. You know, you'd think that a head of an endocrinology department at Hopkins would be able to provide some evidence, if there were any,
right,
that TSH measures thyroid function. But again, it's like, it's a religion. It's a religion.
So, Donna, you really feel like the over-reliance on the TSH test is doing a serious disservice to thyroid patients and putting doctors in a difficult position because they're not really able to properly diagnose and treat their hypothyroid patients. You, in the book, bring up a really interesting parallel to the situation of diabetes, another endocrine condition, and obviously one that's probably more well known and in public than necessarily the hypothyroidism diagnosis and treatment process. Can you tell us why you feel that the comparison to diabetes is valid and how it affects thyroid diagnosis and treatment for patients and for practitioners?
All right. Well, first, both insulin and thyroid hormone are large molecules. And with the treatment of diabetes, the diagnosis and treatment of diabetes, we've all been taught to measure blood sugar as the measure of the function of insulin. What we don't measure with managing diabetes, of course, I don't manage diabetes, but those who do, they don't focus on the amount of insulin present in the bloodstream, but they measure the function of insulin, which is blood sugar. And that's based on the concept of insulin resistance, which means essentially that we know insulin is present, but it is not working because we see that even though there's plenty of insulin present in a diabetic, the blood sugar is sky high. So that's what type 2 diabetes is. The presence of plenty of insulin, in fact, even more than an average non-diabetic person, but yet the insulin isn't working, and that's called insulin resistance. And as far as I know, all doctors believe that concept of insulin resistance, which means a large molecule hormone can be present in the bloodstream, but it's not working. So comparing that to thyroid, what have we been taught in medical school to measure in thyroid? Well, TSH. And what does that reflect? That reflects the amount of the hormone. What it doesn't reflect is the function of thyroid hormone, which of course is metabolism. So if we wanted to manage thyroid properly, just like we manage diabetes properly, we would measure the function of thyroid instead of the amount of the hormone, because many of us believe that there is such a thing as thyroid resistance, and there are articles published about that, which means that thyroid is present in the bloodstream, but it's not working. So if you continue to manage hypothyroidism based on the blood tests, the TSH, even T3 and T4, free T3 and T4, you're measuring just the amount of the hormone, and then you're assuming that the hormone that's present is working. And I think that that's a false assumption, because we know that such a large molecule as thyroid hormone can be damaged, broken, misshapen, The hormone may be present and floating around in the bloodstream, but it's not getting into the cells and doing what it's supposed to do in the cells. So that's why, from a molecular level, the TSH really isn't the right answer for managing thyroid. Instead, we need to measure the function of thyroid, which again is metabolic rate. Well, how do you do that? Well, guess what? We don't have a blood test for metabolic rate. You can actually, in England, I think you can measure ATP production, which is to some extent a measure of metabolism, but we don't have that test here, and it would be very expensive to get it. The reason I manage patients based on clinical clues is that's the best way that I know of to measure metabolic rate. So take your patient's temperature, have them take their morning temperature, have them take their pulse. How's their energy? How's their ability to heal injuries, for example? Those are all, how do you metabolize food? If you have a cup of coffee, does it make you excessively jittery and you stay jittery for hours? That suggests your metabolism is missing in action or sluggish. So that's why I focus on clinical clues, because those are the only way I know. Those are the only clues I know for measuring metabolism. And if you can measure metabolism, then you can measure thyroid function. But the blood tests, just like, you wouldn't want to manage diabetes by measuring the patient's insulin level, because your patient's going to get her sugar is going to go sky high and going to end up in a coma or dead or something because the blood sugar is so high because you're functioning on measuring insulin. I think that doctors need to think about that. Is there insulin resistance? Yes. Is there thyroid resistance? I believe yes. And many others believe that too.
Talking about patients and what they're up against, as a patient advocate, I run into the stories all the time. I've had coaching clients and patients write to me that they've been fired by their doctors for asking for everything from T3 treatment, natural desiccated thyroid, or saying, hey, look, if I get a bone density test on a regular basis and you run a EKG, could you please keep my TSH lower? Then that'll at least cover you, as far as any of these particular problems. Doctors will laugh at the patients, they berate the patients, they fire the patients. In some cases, they're very patronizing, and they say, well, obviously you've been reading Dr. Google, and blah, blah, blah. And what do you say to patients that are dealing with this kind of stuff, where they're coming up against doctors who are looking at them like they got two heads and saying, you're out of your mind. We're not doing this.
Well, I tell them, find another doctor. When I have talked to patients, since I retired, I said, is your primary care doctor open-minded?
Mm-hmm.
Do you think they would be willing to give this a chance? Of course, a lot of them are optimistic and say, well, yeah, she's pretty nice. And then, I just
run into it. Yeah.
Ask if she knows a thyroid that makes you clinically well and the TSH ends up to be 0. Dr. Jones, how are you going to respond to that?
Mm-hmm.
And I've asked other doctors, when I try to refer patients to somebody,
that's a good question.
How will you respond to a TSH of 0 if the patient is absolutely clinically well and her bone density is not going down and everything, and the pulse is perfect and everything else? And you just have to, you can't train a closed-minded doctor. And of course the endocrinologists are the high priests of the religion of TSH. So the endocrinologists are the least open-minded in my experience. I do have one endocrinologist who's a friend of mine, and he's pretty open-minded. But again, if he starts treating and has a bunch of patients with TSH of 0, because that's what it takes to make the patient well, he's gonna, people are gonna jump down his throat as well. So you have to have guts, and maybe you have to be practicing in some small little town where there aren't any endocrinologists breathing down your throat.
Good point.
Which is sad, but you just have to find open-minded doctors, and it has to be in a state that allows the doctor to be open-minded. I mean, there are, certainly we've all heard of doctors who've been persecuted for treating COVID with drugs that work, like ivermectin and hydroxychloroquine. Doctors have lost licenses, they've lost their careers, their jobs. Of course, when a doctor works for a hospital, the doctor has to do what the hospital wants them to do. So you generally have to seek out the doctor who works for themselves. They probably don't take insurance because, again, insurance is going to tell the doctor what to do.
What they can and can't do, right?
Those are, there are still some of us around who practice on their own. And you just have to find that doc who's open-minded. And, there are different places. Again, in the book, we have a list of references of where you might find those types of docs, but it is hard. And that's why, one of the big reasons why I wrote this book, to, if the patient can find that open-minded doc who's maybe young and is thinking and not just doing what the protocols tell them to do, they can read the book and say, oh, gee, this makes sense. This makes sense. And if they do have the freedom to be able to practice as they see fit, if they're in the right state, if they're, if they're working for themselves, then great. They can learn from my experience. And it's kind of a cheat sheet for how to do this. But, again, if the gray-haired endocrinologist who's been doing it the same way forever don't even waste your time. Do not waste your time in that office. You're don't argue with these guys. I've tried it. It's a waste of time.
Yeah.
You just have to be searching.
Another the issue of TSH versus symptoms. This is one of the controversies, but one of the other controversy areas is the use of different thyroid hormone replacement drugs. We still have a fairly good subset of endocrinologists and regular doctors who refuse to use any T3 in their treatment. They rely solely on synthetic T4, levothyroxine, like a Synthroid drug. And they will not use even adding synthetic T3, much less natural desiccated thyroid, which creates apoplexy in some of these doctors because they just, I've heard every story in the book from some of them. It's made from cows. No, it's actually not, and you're going to get mad cow disease. No, it's not regulated at all. And, people are cooking it in their bathtubs. No, not exactly. I mean, they have so many crazy stories about it. And the fact is, as we said before, some of these drugs work very well for some people. It's not a one size fits all. But do you find in general, which is sort of the trend that more patients than not often end up needing some component of T3 in their treatment, whether it's adding a little to their T4 treatment or taking some natural desiccated thyroid, versus folks that do great on levothyroxine drugs alone, or like a Synthroid alone?
Many, if not most, need some T3. And again, in the book, I talk about what symptoms suggest lack of T3 and what symptoms suggest lack of T4 to give the future doc a kind of an idea of, okay, what's going to work here, what's going to work there. But then it's a moving target. Like, again, myself, I started on a synthetic copy of Armour Thyroid. That's when I wasn't eating any pig products many years ago. And it worked fine for me at that time. But later, over years, I just found that I didn't need the T3, and the T3 was actually causing some symptoms. So I am currently on just a T4 product by myself. But, some people need T3 forever. It's just, again, you just give the patient what they need. It's like, well, what's the best blood pressure drug? Well, there are a lot of different ones, maybe they need a diuretic, maybe they need a hydralazine or something like that, so try this, try that, see what works, give them what works. So this is the same thing with thyroid. It's fortunate we have a little bit of choice in our thyroid products. And, if the patient doesn't do well on just this, then give them that. And if things change, then change it along with the symptoms. So again, if you know what symptoms are indicative of T3 versus T4 absence or excess, then you know how to adjust their dose. So, but I would say, yes, most people need a little T3.
The book has, just for people who aren't familiar with the book yet, the book has checklists. It has all sorts of really helpful information. There's an incredible appendix with lots of resources in it, with places that Dr. Hurlock recommends that you can get more information. And there's just an incredible wealth of information about all the symptom areas and body systems that are affected by the thyroid. Many of them, a lot of patients aren't even going to realize are related to their thyroid. How do you feel that a thyroid patient, maybe the typical thyroid patient who says, I'm on thyroid treatment, but I just don't feel great. How can they use this book as part of their wellness journey to kind of get on a more successful, better path?
Well, of course, since it's the patient is the most motivated person to get better.
Yeah.
So the patient is going to be a very good student of learning how, well, gee, maybe if I take the dose twice a day, break my dose into half, take twice a day versus once a day, that might make me sleep better. It might make me have better energy at lunchtime. If they're on just T4, but their skin is incredibly dry, they're going to realize they probably need to add a little T3. And then they can, again, if they have an open-minded doctor, they can maybe encourage the doc, hey, or suggest to the doc, hey, can we try a little T3? I've read in this book that it might help my dry skin or my hair loss. I don't have any symptoms of T3 excess. I'm not jittery. I'm not hyper. So maybe could I try a little T3? Again, it's helpful to actually have an MD behind your name, so then you can kind of adjust your dose yourself. But that's, that's a luxury that not all of us have. But
right.
And then again, if you find that open-minded physician, maybe a naturopath, maybe you're in a state where naturopaths have prescribing abilities, or a DO. DOs tend to be, and I believe, a little bit more open-minded. Again, it's an individual thing, but
sure.
So the patient can maybe help make suggestions for how to adjust the dose. And of course, the patient needs, above all else, to recognize symptoms of overdose. So, and again, I spent a lot of time educating my patients at the first visit, giving them a list of, okay, these are the signs and symptoms of overdose. You must watch for these every day. You must monitor your pulse every day. We don't want to do any harm. We don't want you to be overdosed because, again, your other doctors are going to think you're overdosed based on the blood test. I don't want them to be right. I don't want you to be overdosed. You've got to watch for these symptoms. So that's, of course, extremely useful for the patient. In order for the patient to do this successfully, they need to understand what's going on with their body. And of course, this book helps them do that. So it helps them be safe and helps them achieve wellness if they have a physician who's open-minded and is willing to learn.
Well, one of the things I love most about the book is the fact that you are writing to both patients and your colleagues, your fellow practitioners, fellow clinicians. And so as a patient reading the book, you get a little bit of an insight into why you are communicating and how you're communicating with my doctors and the reader's doctor, the reader's practitioners, the person that's going to be deciding on the thyroid care. And I also love the parts of the book where you address the practitioners directly and you say, like, what did you learn? Why are you doing this? I think you were more restrained, and I'm sort of waving my hands around, but you were much more restrained about it. But you kind of sounded a little bit like you wanted to shake some of them and say, hey, come on, get with the program. And so what would I know that we have some practitioners that'll be watching this interview. A lot of them follow me, and whether they want to see whether I'm out of my mind today or, if I've got something good to say. But what would you tell the practitioners watching this about diagnosing and treating hypothyroidism and how your book might be able to help them provide better care to their patients.
Well, I would say to them, be brave. Be brave, because fixing somebody's hypothyroidism is one of the most fulfilling things you can do. You can truly save people's lives, make their lives infinitely better. I've had patients on disability, they can't work. They're in bed 20 hours a day. Their cholesterol's messed up, their sugar's messed up. And just by giving this safe hormone, again, if you know what you're doing, you can make all that go away. And what a wonderful thing to do for your patient. I mean, ideally, doctors you go to med school to make patients' lives better. At least that's what I did. They told me I shouldn't say that when I applied to med school, but I did. But, most doctors, I think, want to make patients' lives better. And this is such a effective way to make patients' lives better, who in some cases are absolutely miserable. It's very satisfying. It makes you go home feeling good, knowing that you've made somebody better. Just like, saving a life by giving them hydroxychloroquine. That's pretty satisfying. Don't be afraid to try to do that. But again, at the same, and again, hopefully this book gives you some helpful hints for what you need to know, so that you can learn these skills, which of course aren't taught in medical school anymore. But at the same time, be very careful, document everything, make sure your patient's watching for any overdose. You don't want to do any harm. If you're doing something that's different from the pack, you don't want anything bad to happen to your patient. So you have to just absolutely, have the patient sign a consent form that they are aware that this is different from the quote standard of care. Ideally much better than the standard of care. Make sure your patient understands how important it is to be cautious. But my God, there's such room for improvement by doing this, that it's just, I think it's a crime not to do it. Obviously it's not a crime, but to do no good, I think, is to do harm, particularly when you know that you can do good.
Absolutely.
So, again, hopefully the book, just like Rhoda Barnes' book from 1976, which of course we all know about, Rhoda Barnes opened my eyes, and my ex-classmate Alan Gaby from med school, he told me to read Rhoda Barnes' book when I was talking to him about my hair loss and my constipation and my coldness, etc. And I read this book and I said, oh my God, why didn't anybody teach me this stuff? And it's just like my eyes were opened, because I learned all this clinical information that I had never been exposed to, even at University of Maryland, which was a relatively clinically oriented medical school. But, I learned the whole TSH dogma when I was in med school, and, you report, 2, 3, 2, 4 TSH values are blah, 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 blah. And, you pretend that you know what's going on with the patient. And of course you don't. But, this is just a better way that you can really help patients if that's your goal. If your goal is to just punch in and punch out and make money and go home, don't even go there.
Yeah.
And don't go there if you have a patient who's not willing to cooperate. You need your patient to be serious about it. They have to know the importance. It's not candy. You can hurt people with thyroid if you're not careful. It's certainly not as dangerous as insulin, for example. It's easy to hurt somebody with insulin, but you can do harm with thyroid. You have to be a grown-up and be willing to monitor. Your patient has to be willing to monitor. But if you do have the educated and motivated patient who can take their pulse, have them get one of those cardiomobile things. They can take their pulse with that. It tells you if you're in atrial fib, for example. You never want to be there, but It's easy to reverse if you just stop your thyroid hormone, as long as
Right.
it's been there for months and months. But, you have to have a motivated patient. If you don't have a motivated patient, don't even try it. Don't put yourself and them at risk. But if you do have a motivated patient and an educated patient, hopefully this book can, if they both read it, then they'll know, okay, well, this may work this way, so let's try this and then just see what happens.
Well, and I want to make it a point to the patients that are watching. If you're listening to what Dr. Hurlock is saying, she's saying that in order to work with a doctor who's going to do things a little bit more innovatively, you have to be a motivated patient too. Doctor's not going to come along and impose everything on you. You need to be in partnership. It's a two-way street, and you have to be doing the things and that your doctor's asking you to do to protect yourself, keep you safe. But that's also for the doctor's protection too, because doctors don't want to get sued for patients that are ending up over-medicated or doing stupid things with the drugs that the doctors are prescribing.
Of course.
And so patients need to understand that, I've heard too many people say, well, they give me a pill, I take the pill. That's, I'm not that, I don't know what my TSH numbers mean. I don't know what this. And I say to people, look, you have to understand what you're taking. You have to understand the condition that you have, and you need to understand what physiologically is going on, because your slow digestion, your hair falling out, all of these things are related to your thyroid. They're not all independent conditions that have all befallen you at the same time. But people who aren't willing to get a knowledge and be a little bit more empowered about it, sometimes they're wandering around in the wilderness, and they're not going to be motivated patients, and they're not going to find doctors like you that are out practicing today who are going to be willing to work with them if they're not also being
for sure. Yeah. I mean, non-compliant patients was my biggest fear, patients that wouldn't monitor their pulse,
exactly.
Or whatever, it's like, you're not only putting yourself at risk, you're putting me at risk too. And, if you want me to have something bad happen to my license, okay, then who's going to take care of you?
Exactly.
So
they have to, it's a two-way street.
Being careful, keeping everything documented, have the patient sign a consent, a good detailed consent, and have them know. I practiced outside of Washington, D.C., and I had incredibly intelligent, highly motivated, highly educated patients that knew there was something wrong, and they had, many of them had been to many other doctors, and they knew, their mothers knew, I know you have a thyroid problem, but the doctor won't figure it out. So they're pretty easy to take care of because they already know what's going on with them, and they've already tried this and tried that and tried that, and it's like, well, okay, well then let's try this because all those things didn't work. So you have to have that kind of patient.
My thanks to Dr. Donna Hurlock for joining us today to share more about patient-focused hypothyroidism treatment. You can learn more about Dr. Hurlock and her book at her website, www.drhurlock.com. There's also a link there to purchase the book from all of your favorite online bookstores. And the book is available as both a paperback and an ebook.